Good afternoon. Looks like we have folks that are coming in. Thank you all for being in community with us today as we continue our conversation on intimate partner violence. Welcome, welcome, welcome. All 220 of you all are coming in, so we're going to give a few minutes. And as you come in, if you don't mind, just in the chat really quickly, let us know your name, where you are joining us from, and something that brings you joy. Something that brings you joy. And I'll read off a couple of those, but welcome everyone. So good to see some familiar faces from the other sessions and names. Oh, it's going so fast. Let's see. I see family brings me joy. Kids, dog, yes. Someone said they love the sunrise. That's beautiful. I'm not up there early, but I'm sure it's amazing. Helping others, being outside with nature, music. Yes, beautiful. Yeah, I see a lot of family. A good book. That's amazing. Good weather, good food. Who doesn't get excited when they taste something that tastes so yummy? All right. So many amazing things. Please continue to add your name, where you're joining us from, as well as what brings you joy into the chat. I love to center ourselves. We're talking about a hard topic. And so I love to center ourselves in what brings us joy. All right. So I am Dr. Gia Kelly. If you have been a part of this month-long series, then you probably know me by now, but some of you all, this may be your first session. And so I want to personally welcome you and to say thank you. And I am just a facilitator for this space, really creating this space for us to continue our conversation. This particular session will focus on best practices for clinicians who really desire to support survivors and their children. And even those of you who may be working with those who cause harm, right? This session is for you to really dig into what should we be doing? I want to say that the focus is really on survivorhood and elevating the voices and amplifying the voices of those who have been impacted by such violence. But we invite you to ask questions, so we will leave room for questions in our time together. So again, thank you for being here. Let's move forward. So just as a part of our disclaimer, we want you all to know that this particular webinar has been funded through a cooperative agreement with SAMHSA. And while this event has been supported by SAMHSA, the contents are those of the authors, right? And do not necessarily represent the official views of SAMHSA, HHS, or the US government. So we like to just let folks know that. Also, if there was to be a breach in our security for any reason, we want you to know that we will immediately end this session and email out a new link so that you all can join that new link. We do not anticipate any security issues, but we like to put that information out early in our session. And so our agenda for today is pretty straightforward. I have already welcomed you all. I'm going to give a little bit of an intact overview of who we are and what we do. And then I'm going to hand it over to one of our panelists, Gabriella, who is going to talk and center us in really understanding the intersection of mental health and intimate partner violence. And then we'll open up our panel discussion where we have three amazing clinicians who have experience in this area, and we'll be able to have a really deep discussion. And then we'll open up some time for any questions that you might have for the panel. I believe the discussion will help to hopefully answer some of your questions, but we will leave a little time for any questions that were not addressed in the discussion. And then we'll have our wrap up. So just a little bit about NTAC. NTAC is the National Training and Technical Assistance Center for Child, Youth, and Family Mental Health. And we are a collaborative effort between all of these amazing collaborative and national partners that have come together to bring their expertise and their subject matter knowledge to help inform the field of mental health by creating products, resources, and sessions like the one that you're attending today in order to enhance the behavior and mental health fields. And so you can see our wide array of partners who make up the INTACT team. I am employed by Change Matrix. And so again, you can see some of our other partners as well. Our vision here at INTACT is really that all children, youth, and families that are living with and impacted by mental health challenges will have access to the resources and opportunities that they need to thrive in a comprehensive and equitable system of care. And so all of our offerings are really to get us to that vision. We invite you to please go to our website and see our wide array of free, I'm going to say that again, free services that we offer to the field. And those services range from individual consultation to more in-depth sessions like today's webinar. We also have peer learning exchanges and tools to help you. Our aim is really to create outlets for communication, collaboration, and resource sharing for us all. So we do invite you to go to our website, which will be dropped. A link to our website will be included in the chat for you. So just a couple of commonly asked questions that we get after these sessions. We'd like to address this up front. Folks may be wondering, will I get a certificate of completion? You absolutely will. If you have registered and you are attending today's session, you will automatically be emailed a certificate of completion after this session. Also, we will be recording this session or are recording this session. And so you will get a link to that recording as well as the slides from today's presentation. Yeah, so that should be to answer some of the questions that you might have as it relates to what happens after today. So again, today's session is entitled Best Practices for Mental Health Clinicians, How to Help Survivors of Intimate Partner Violence. October is Domestic Violence Awareness Month, and that is why we chose October to do this series. And so for those who don't know, DVAM, or Domestic Violence Awareness Month, is a time where victim advocates, allied professionals, survivors of abuse, their loved ones, and surrounding communities come together to mourn the lives that have been lost to domestic violence, celebrate the progress that has been made to end this epidemic, and to connect with others who are working to create change. INTACT wants to honor this month through this webinar series and to bring awareness to the impact that IPV has on the mental health and well-being of children, youth, and young adults, as well as families, but also to center the resilience and strength of survivors in this conversation. One other thing that I want to encourage you all to do is to take care of yourself. We are talking about, again, a topic that can be triggering for some. We do not, we understand that because of the stats and because of how prevalent IPV is, there's someone on this session today, or many people who have been impacted. And so we just encourage you to please take care of yourself. If there's anything that is hard to listen to, or you need to remove yourself from the session, or take a walk or get off camera, whatever you need to do, we want you to do that. And also we want to provide you with the National Domestic Violence Hotline information if you need some support. So you should see that on the screen. There's a number to call and a number that you can text, and it's also in the chat for you. So if you don't need it, feel free to pass it along to someone who might need it. All right, I'm heading out of your way, but I would like to briefly introduce our panelists today before I hand it over to Gabriella to ground us in some information. Today's panelists are just so amazing. I'm so excited that they took time out to be with us today, but you'll see on the panel today, Dr. Jean Clark Mitchell. Dr. Jean Clark Mitchell has been in the domestic violence and sexual violence movement for nearly 30 years. She's been the clinical director of the Elizabeth Freeman Center and is a founding member and current board member of the Massachusetts Women of Color Network and a professor of social work at Lesley University. Her work and research is focused on increasing awareness of the effects of domestic violence on individuals and families. So help me in welcoming Dr. Jean. You can do your emojis and all that good stuff. You all probably know how to do it better than I can. Our next panelist is Marissa Williams. She is a licensed professional counselor and certified clinical trauma provider and has 12 years of experience providing therapy, advocacy, and support to children, adolescents, and adults. She has experience providing therapy to people with a variety of mental and behavioral health needs, to include those experiencing symptoms of depression, anxiety, and adjustment. She's a certified clinical supervisor and is able to provide support to therapists in training, working toward their licensure. Combining her education and experience, Marissa specializes in providing therapy to therapists and advocates working in the IPV movement. So she's helping those who are on the front line of this work. So we're really grateful to have Marissa on our panel today. And last but not least, we have Gabriella Zapata Alma. Gabriella is the Associate Director at the National Center on Domestic Violence, Trauma, and Mental Health, as well as a lecturer at the University of Chicago, where they direct the alcohol and other drug counselor training program. Gabriella brings over 15 years of experience supporting people impacted by structural and interpersonal violence and their traumatic effects through the innovative and evidence-based clinical, housing, resource advocacy, peer-led, harm reduction, and HIV integrated care programs. As a person with lived experience of violence and trauma, they center survivor-driven solutions, non-pathologizing I can't speak today. Non-pathologizing approaches and intergenerational healing in their work. Sorry, I can't speak today. Currently, Gabriella authors best practices, leads national capacity building efforts, and provides trauma-informed policy consultation to advance equity and justice. So please help me in welcoming Gabriella to our panel. All right. So I am going to actually hand things over to Gabriella to talk to us a little bit about the intersections of intimate partner violence and mental health before we get into our discussion. Over to you, Gabriella.
Thank you so much. And thank you so much for having me and for welcoming me and offering just a little bit of information before we have this phenomenal panel discussion. Next slide. So we know that being victimized by an intimate partner has effects on our mental health and on our relationship with substances. First, I want to say I woke up with a sore throat, so if anyone has trouble hearing me, I apologize in advance. I'm doing my best to work through this sore throat, but that's why I'm speaking a little more softly today. So we've known for decades that being victimized by an abusive partner is associated with physical health effects. But we also know that there are impacts on our mental health and on our substance use. So experiencing domestic violence has been associated with a 3 times higher rate of experiencing post-traumatic stress disorder, major depressive disorder, and engaging in self-injury. A 4 times higher rate of suicide attempts, and then a 6 times higher rate of developing a diagnosable substance use disorder. Next. We also know that pretty large rates of people in mental health care report experiencing physical abuse or sexual abuse from an intimate partner. And so this research that I share here is specific to the experiences of women. So this is largely because women have been disproportionately impacted by domestic violence. And so in the research, our research has focused largely on women and the experiences of women. Research has very often also defined domestic violence as physical violence or sexual violence. And yet we know that domestic violence is so much more than just physical violence and sexual violence. And so these numbers that I'm about to share are actually artificially low because there's a lot of people experiencing this who maybe haven't experienced the crisis of in a way that is physical or sexual yet. And so, from the research, we found that 30% of women in mental health outpatient settings report experiencing domestic violence, 33% of women in inpatient settings, and then that number really jumps up from that 30% to 30 to 60% of women in psychiatric emergency settings. Now, we know that men are also impacted by domestic violence and by trauma more broadly, trauma that may include domestic and sexual violence. And something else that I want to point out here as well is that transgender and gender nonconforming and non-binary people, in the little research that's available, also experience increased rates of domestic violence, but very often have their gender identity erased from the research. And so there's a lot that we need to do here in order to be more gender inclusive, while also recognizing some of the unique experiences that women face as survivors of domestic violence. Now, taking a moment to look at these stats, these are astronomical. When we think about that 30% of people who we may be seeing in our clinical practice are experiencing domestic violence or have experienced domestic violence. I mean, imagine if that were anything else. If we were to say that 30% of the people that we serve experience, let's say, anxiety, right? Then we would want to make sure that we were really skilled in supporting folks experiencing anxiety. And yet, too often, domestic violence is not included in our counselor training programs, and people are really seeking out this information after recognizing how incredibly common these experiences are in their practices. So, all that to say, I'm so glad that you're here today, and I'm so glad that this is getting more talked about and that we're having this session, and that this session has been a part of this series. We really need to continue these conversations. Next slide. And we know that children and other family members are also impacted, and that while exposure to domestic violence can impact children's well being, that attachment to that protective primary caregiver is what has been found to be most protective for children's resilience and development. And at the same time, far too often, the tactics of abuse specifically target a survivor's attachment with their children and specifically look to undermine survivors as parents, as caregivers, and to really threaten that parent child attachment. And so we want to be aware of all the ways that not only are there mental health impacts on survivors and their families, but then how those tactics of abuse seek to really further the damage of those impacts as well. And so here at the National Center on Domestic Violence, Trauma, and Mental Health, you can go forward, that's fine. When we say survivors, we usually use that word to mean everybody in that family system who is being adversely impacted by the domestic violence. Not just the individual, but really taking a family perspective. At the same time, we know that domestic violence is very often not the first stressor, trauma, crisis, or adversity that survivors face. And that many times survivors are actually coping with the burden of cumulative trauma. Um, Starting sometimes with adverse childhood experiences. Sometimes this is also starting with the burdens of historical trauma and intergenerational and collective trauma. But looking specifically at adverse childhood experiences, they have been found to increase the likelihood of both experiencing domestic violence as well as causing harm, as well as causing domestic violence. And something I'll mention here is that, you know, we want to be sure that we're pulling the lens out to look at, yes, household adverse, childhood adverse experiences, but also looking at community level adverse experiences as well as environmental adverse experiences. And so here, being able to recognize how things like experiences of bullying and out of home foster placements have also been linked to increased risk in the areas of health, mental health, substance use, domestic violence, heart disease, cancer, and especially when there is poverty. And that poverty is violence, poverty is human made, and poverty is something that exacerbates every other risk. But looking specifically at mental health and cumulative trauma, in order to understand the relationship between domestic violence and mental health, part of what we need to do is that we need to start contextualizing how things that we may call mental health symptoms or that we may use in mental health to understand a mental health diagnosis um, also develops in the context of domestic violence as a form of coping and surviving and self-protection. And so as a trauma therapist, I will always share with people that while the symptoms they're experiencing can be incredibly painful, can be incredibly distressful, that at the same time, they're also part of their body and their brain's genius in attempts to survive and protect themselves. So understanding all of these symptoms or symptoms, I should say, as trauma responses and forms of coping and survival that are part of that person's unique life experience. Next slide. Now, in addition to those mental health impacts, less well recognized are the ways that people who use power and control over their intimate partner use coercive tactics that specifically target a survivor's mental health. Next slide. So, the National Center on Domestic Violence, Trauma, and Mental Health, we partnered with the National Domestic Violence Hotline to conduct the first nationwide quantitative study on coercion related to mental health as well as substance use. And I want to share just some of the findings from the mental health arm of this study. So, what we found is that in a survey of over 2,500 callers who were not pre screened for experiencing mental health, these were just general callers to the National DV hotline, that 89% had experienced at least one type of mental health coercion tactic. So that's 89%. That's enormous. That's mind boggling. That is, almost 90% of callers, right? This is how incredibly common mental health coercion is. So 4 in 5 callers said that a partner had accused them of being crazy. 3 in 4 said that a partner deliberately did things to make them feel like they were losing their mind. And this is a tactic of abuse, often called gaslighting. 1 in 2 callers said their partner threatened to report that they were quote unquote crazy to keep them from getting things that they wanted or needed. And this was most often things like order of protections and custody of their children. And we see time and time again that when, based on our analysis of custody court cases, that when that partner who causes harm introduces allegations around mental health, that it is much more likely that then custody is awarded to that unsafe partner. And that 1 in 2 had sought help due to feeling depressed or upset. But of those who sought help, have said that their partner tried to prevent them from getting the help that they wanted or tried to prevent them from taking their medications as prescribed. Next slide. So, in that survey, we only asked about a handful of tactics. And something I'll say there is that people who are at the greatest risk of experiencing all the different tactics were most often people of color, right? And I'll say a little more about that in a little bit. So, mental health coercion tactics generally use mental health and mental health stigma to exert power and control over a person. And then, as part of that, they undermine a person's mental and emotional stability and their overall well being, doing things like interrupting healthy routines, keeping people up all night, keeping them away from loved ones, things that really threaten their mental and emotional well being. Many times will also exploit a person's mental health for personal or financial gain, and will work to then use all of this to jeopardize that parent-child attachment. Will often use mental health to justify or rationalize the abuse or make it seem like the abuse is not actually abusive. Then, of course, we'll use mental health and mental health stigma to discredit survivors with any potential source of safety or support. And then, of course, sabotage access to any kind of mental health support that could be useful in that a person may use in trying to support their own well-being. Next slide. In that study, we also found in the qualitative arm, so the arm where we were asking people about to share their experiences with us, we found two major categories of tactics. One was manipulation of treatment, and the other was control of medication. And we can go ahead and get those up on the slide. Thank you. So things like trying to influence the mental health diagnosis or treatment, the threatening or attempting to have somebody forcibly committed against their will when it's completely unnecessary, withholding resources that a person needs to access care. And sometimes this is really obvious. Sometimes this is like a person refusing to allow that the insurance that the family has be used for mental health care, right? Other times, this is more implicit, this is more covert. Things like, promising to watch the kids so that a survivor can do a mental health intake. And then when they're supposed to be there to watch the kids, they're nowhere to be found. And then the person misses their intake because they can't arrange childcare at the last minute, right? So this really runs a spectrum from really obvious to really subtle. And then pathological jealousy, a lot of allegations and uh, accusing somebody of having affairs with a counselor or things like that. Then we also found a whole set of themes around medication, preventing the being able to take medication or forcing to take medication and over medicating, stealing their medication, or of course, then insulting and denigrating the person for taking medication. Next slide. Some additional things that we want to be able to listen for is really undermining somebody based on their mental health, um, blaming them for their mental health, that gaslighting we talked about earlier, jeopardizing a person's mental health, so doing things to really cause their mental health symptoms to get worse. Very often, when somebody has had a mental health crisis, there's some kind of trauma or abuse root that may have triggered that mental health crisis. And so being able to get a sense of what was going on during that time that initiated this crisis. Of course, the discrediting, the threatening, and then the controlling behavior. Next slide. And so here, sharing a couple of the different things that people shared with us in that same survey. So these were two different survey participants, and I'll just share what they shared with us. He'd tell me I shouldn't get any help or take medications because he didn't want anyone to know about my depression. He'd say things really softly under his breath. And when I asked what he had said, he'd tell me I'm crazy and that he didn't say anything. And then someone else shared with us. He told me if I tried to leave, he was going to take the kids and I would be in a psych ward. Next slide. And so mental health differences really increase the risk of someone being abused by an intimate partner. And it's because of the stigma that anything that can be used to harm a survivor will be used to harm a survivor. And because of mental health stigma, then anything around mental health is being leveraged to really harm survivors. And then this, um, anywhere where a person experiences marginalization or structural violence, then this creates even more barriers to help and really amplifies the effects of that abuse. Next slide. And so that structural violence and that interpersonal violence, they go hand in hand. They are inextricably linked. And so, for example, um, if I am experiencing the cumulative effects of trauma, as well as having all of these social determinants of mental health because of the legacies of discriminatory policies and historical trauma, right? And ongoing structural violence. And then on top of that, I'm having somebody who is specifically gaslighting, jeopardizing my mental health, and then sabotaging my access to mental health. And then when I finally do get access, what I'm met with is a therapist who isn't culturally responsive and pathologizes my cultural strengths. And I actually experience discrimination in that mental health care. Right? We see how all of the interpersonal violence and the structural violence just link together. And so we cannot end interpersonal violence without also ending structural violence. Next slide. And so I just have a couple more slides here left, and then we'll get to the panel. So how do we heal? How do we heal when we are actively being coerced and sabotaged, and there's someone who is still actively trying to harm us, right? There are so many different evidence-based practices and clinical approaches to address post-traumatic stress disorder, but when we're working with survivors, many times the trauma is not post. There's ongoing targeting and threats. Even if a person has left a relationship, many times that's when danger increases for people. So, what can help? And so, based on our systematic review, we found, oh, next slide, we found five key elements that can enhance existing evidence-based or promising practices. So, first, being able to offer psychoeducation around the true causes and consequences of intimate partner violence, including the traumatic effects of IPV. Second, awareness of coercion related to mental health and substance use and their effects, and how they work to sabotage well being. Third, attention to ongoing safety and partnering with folks around safety planning. Fourth, cognitive and emotional coping skill development that can help address trauma related symptoms and support people in their self defined goals. And finally, fifth, a focus on survivor strengths, as well as including personal as well as cultural strengths on which they can draw. So these next set of slides just have a bunch of free resources that we have available, and you have them in your copy of the slides. With that, I will pass it back to Dr. Kelly so that we can kick off our panel.
Thank you so much, Gabriella, for kind of grounding us in that intersection. So much great information in such a short period of time. So again, we will send these slides out for those who are like, I could take notes, but I want some of that. We will provide that to you. And so we are going to transition into our panel discussion. And in order to do that, I want to make sure that we spend time together. So I'm going to actually stop sharing so that we can have more of a conversation. All right. And I'm going to ask if questions come up for you, I'm going to ask that you will write those down, and we will leave time at the end, just so we're not checking the chat while we're trying to do the panel. So if we can just, you can just note your questions, and then we'll give time to ask those. All right. So let me stop sharing. And hopefully our panelists are all here. Good. All right. So we're all spotlighted. So I'm sorry. So my first question to our panelists who have diverse experience and expertise as it relates to both mental health, being a clinician, as well as their own lived experience, I wanted you all to just tell us a little bit about how you came to this work, how, what brought you to this intersection of mental health and IPV. So anyone can start with that question. How did you come into this work?
Good afternoon, everyone. I'm Marissa Williams, and I'm grateful to be here. I actually started out in the criminal justice side. I actually witnessed his mother murdered by my father as I was a child. And so I got into advocacy after studying victimology because I wanted to help people. I wanted to make sure that people had adequate supports. And as a child and growing up, I didn't feel like the supports were what I really needed as I grew and learned more and more and more about mental health. So I landed a career, went back to school for training as a trauma therapist. And from there, so I did some time in between my studies and the career change, working through several nonprofits as an advocate. And I noticed the lack of mental health support for advocates that were doing work. And so I prioritized being a caregiver from the mental health perspective for those who are caring for others.
Mm. Thank you so much. So much in that little introduction, right? Your own experience. And I think you may have went out a bit, but being a child survivor, having your mother murdered by your father, huge, right? But that leading you into studying trauma. And we just want to sit with that, right? That's real. That happens. And I always want to make sure that we understand that lives are lost as it relates to this. Like, it's not just something that impacts folks, right? But it really takes lives. And so, Marissa, thank you for sharing that with us, and your commitment to the work, and supporting advocates. And so I think you bring a really interesting aspect. And so who helps the helpers? Who helps those who are advocating on behalf of? So thank you for that. Gabriella or Dr. Jean, either of you?
Certainly, I can go next. Hi, everyone. Good evening. I looked at all who's there, and it's like, oh my God, look at all these people. This is so exciting that you're here for this reason today. Yeah, for myself, I started out in a domestic violence relationship. And I took two children, two small girls with me, 6 and 10, to a battered woman shelter. And I found out about that shelter because I was in a domestic violence relationship from my sister, who learned that information from a friend. So I just say that to say that if you know something, share something. And when you know somebody's in that situation. So now I find myself in a shelter. And when I got there, it was mainly women at the time, and we're women helping women. So there was peer survivor work going on with each other. And I thought, I had a degree in business. I came from a purchasing background. And then I thought, but I want to do this. I want to help people the way I was helped. And so while I was in the shelter, I took the hotline training, and it just took off from there. I went to community college, then I went to get my bachelor's in psychology and social work. Then I went social work, and then I went back for my PhD. So today I call myself, a survivor leader, a super thriver, a social work professor, a psychotherapist, an advocate, a global mentor, a mother, 26 years of this work, that work, and then about 30 years now, next year in the movement. So that's kind of my story. And I do it because I love seeing the end result for children and families, because I've done it. I know it. I know there can be such a great life after if we can just help people to be safe. So
thank you, Dr. J. Amazing. Thank you for sharing your story. Gabriella, did you want to offer anything?
Yes, thank you. And I just want to say that, wow, I'm so honored to be on this amazing panel with all of you. Such incredible people here today. So, I am a survivor, both witnessed as a child as well as an adult, my own relationships. And at that time, I really wanted to focus on poetry and on religion and philosophy. And then I decided to take a gap year and work at a nonprofit. And when I saw just the real human need looking right at me in the face, I knew that I could still continue writing poetry, and I could still infuse so much of what I've already learned and how people make purpose and meaning out of their lives, but that I could do that in while addressing real human need as a social worker. And so for me, it's interesting because I lived it. I knew there was real human need. But in some ways, even when we live it, we think we're the only one in some ways. And so recognizing how many people are impacted, recognizing that many times the most dangerous place for a woman is her own home. I knew I couldn't turn away from that once I saw it. And so that has kept me in the work.
Beautiful. Yeah, so we see how lived experience turns into those at the front line of the work. And I think that is so critical. And I think it's the same when we think about system of care and we think about peer support and when we think about those with lived experience being closest, right? Those who are closest to the issue, who know it, doing the work. I can add that I worked for 10 years in the movement. And I'm a social worker, clinical social worker by trade, have done therapy, but was not a survivor. And so I'm also, coming into this work, just realizing like, this is critical. And so it just really shows that there's room for everyone. There's room for survivors in this movement, but there's room for those who are not survivors, right? And just really want to see change in our community, want to end violence. And so I just wanted to add that. So I wanted to humanize us and center us in that, the fact that we are people behind these titles with stories and with lived experience. So my next question is, what are some of the effects that you have experienced as a clinician, some of the common things that you see as it relates to the effects that IPV has on survivors? Okay, I know we list them in our presentations, but just in your clinical experience, what are some of the things that are like top of the list that you see or have saw?
I'll jump in to say that I worked also as a shelter director, advocate, social worker. So I wanted to also recognize those people who are here that might not be clinicians, so to speak, and to say that even though you don't have letters or titles behind your name, the work that you do is therapeutic, and therapy means change, so that you are helping.
Absolutely.
For clinicians and being a clinician and seeing what I've witnessed in the long and short term effects of domestic violence on children and families, that mental health is ubiquitous among them. If nothing else, you're going to have lots of anxiety. There's going to be depression from the sadness. There's going to be anxiety from the fear, PTSD. A lot of people will show up and say that they have other complaints, but when you really assess them, you find that there's domestic violence involved in their day-to-day activities. So that some of the external indicators that I've seen, as I said before, I've seen ADHD, ADD, borderline personality, paranoia. The list just goes on along the spectrum of disorders that we have, and how people present with those, and how we get to what's happening with them, so we can provide a sense of safety. Because at the end of the day, what's needed the most is a sense of feeling safe, having justice, and work towards healing. So thank you.
Beautiful.
And I think for those of us who are here today that might not be clinically trained, there are certain things that we see that aren't associated, particularly with the diagnosis. That can be things from like budgeting, issues managing money, communication style. Maybe there's passive communication or more of an aggressive communication style. So while we look at, diagnoses that we might see, there are some behaviors that someone that you're working with might identify. I don't think depressed, but I have this issue, right? And so making sure that we explore what clients, or even if it's a guest in a shelter, they're sharing with us as they're on their journey. Some of the things that I see the most are going to be the inability to communicate or express ourselves because of all of the other constructs and lack of freedom that we've had within whatever the oppressive experience was. And so definitely communication, poor health because of lack of access to it. And so when we think about how we as clinicians are trained, we're trained to look at, diagnostic criteria. But from the advocate perspective, you might see behaviors or patterns that a shelter guest might have as you're working with them that might let you know this might be something bigger reaction. But 9 times out of 10, that reaction stems from what they said in their presentation, right? When we look at all of the different trauma symptoms that they're actively experiencing in the moment, could lead to that confirmed diagnosis or the pattern of behaviors that we see.
Yeah. Anything
Absolutely.
to add?
Thank you. Co-sign on what everyone has said, and something I'll add to it is how incredibly the domestic violence seeks to normalize itself. And so um, so much becomes encoded as just a part of normal life when actually it is a part of the power and control. And then how people may respond to information as another label, another judgment, or they may respond to information as incredibly affirming and eye opening. And so being able to really notice where someone is and have be able to make space for a room of range of responses that what might be really empowering information for one person may feel like a judgment for
Mm,
another person. And the other thing I'll say is how our bodies and our thoughts become dangerous places for us. How
mhm,
they're this disconnection from our bodies and our sensations, as well as fear from of different thoughts or feelings that may come up. And so the window of the experiences that we're able to connect to and tolerate grows smaller and smaller and smaller. And as we try to keep the pain out, we also lock out the joy,
mm,
right? And so kind of that overwhelming numbness and fear can really become come to the forefront for a lot of folks I've worked with.
Thank you for that. And I'm wondering if any of you all have worked or currently work with like young adults or youth who have been witnesses, or even from your own experience. I'm just wondering if there's anything else that comes to mind when you think about children and young people.
I can respond to that. I wrote my dissertation on caregivers' awareness of the effects of domestic violence, and that
Mm,
will be shared. And a lot of times, what we may see in what we call a position defiant disorder, we may see some of that in the youth. We see dating violence. We see um, behaviors that they've identified with the aggressor, whomever that may be, mom or dad in the relationship. There may be some lots of self-harm. Also, suicide happens. Also, there are a lot of young people in trying to protect their parents, end up in jail.
mhm,
They get criminal charges against them. Lots of truancy. They don't want to leave the home because they want to be protective of that parent.
mhm,
Of course, the depression and that sort of stuff, anxiety and the PTSD and all that. So yeah.
mhm. Thank you, Dr. Jean.
I think one thing that I see a lot, and I specialize in ages 3 to 22 for trauma, and I
Mhm,
do a lot of work with children that have been removed or have been placed in kinship care or in foster care. And the number one thing that I see is a misdiagnosis of other disorders.
mhm,
ADHD, sometimes it's things like, oh, maybe they're on the autism spectrum because they have sensory input stemming from their trauma responses, right? And so I have to be aware of really diving into understanding what some coping mechanisms are for our kiddos, that
mhm,
to a clinician that doesn't have a full spectrum or experience in working with certain trauma responses could look like an ADHD symptom. But is it PTSD? Or is this a way that, it was telling me, hey, my body does feel good, so I'm acting out this way. I need to expel
mhm,
this feeling. And so really being intentional as a clinician to take time to understand what feelings are associated with some of the behavior, especially for our kiddos who are 5, that can't really say what this feels like for them or identify it with words. It's a feeling, and it's either going to be good or bad or however they describe it to us. So taking time to understand from that child's perspective in the way that they're able to share it with you what that behavior means, or what might look like someone who's feet in the classroom could be anxiety because of the fear of going home and to say, hey, I need help with my homework. Is that
mhm,
past homing situation could have exacerbated some aggression. So really exploring what behaviors are before we're so quick to look at what the DSM says. We've got to have 5 out of the 7 criteria met in order to have this diagnosis, but understanding a little bit more about the criteria that that child might meet before we provide a diagnosis, and look at what that treatment plan might look like based upon the needs of that child and their environment. Their environment is going to be key in how they respond, even if they've been removed or are currently in, because they're still adjusting. And that adjustment period can present, with different responses as well, on top of the ones that might have led them to care, or for a teacher to say, hey, there might be something going on at home.
Mm-hmm. Such a good point, Marissa. And people don't understand the trauma of removal. And so when children are removed, that was the area that I specialized in working with child welfare to understand best practices, when children are impacted or in violent homes. And that's a trauma within itself. So that's enough to send children into all of these different spaces we are talking about. So thank you for offering that. And a couple of weeks ago, we had a survivor to talk, and someone from a national organization to talk about and share her story. And we understand that every child can respond differently to the same situation. And so she shared the story of not just her story, but her siblings, and how all of them had different impacts to the same violence, right? And so that's something to keep in mind as well. While one may be aggressive, the other one may be very quiet and not say a whole bunch, right? One may be impacted developmentally, depending on their age range, or may not remember anything, right? And just have some other things. And so we need to keep that in mind. Gabriella, did you have anything about children and youth?
I was just thinking about how, children will very often react and respond differently.
Mm-hmm.
And so being able to look at our children's services
Mm-hmm.
and look at how are we supporting all the children in all their different responses, and that our responses are actually child-centric, and looking at understanding children from their own perspectives and their needs and goals from their own perspectives, and not just trying to apply interventions to have calm children.
Yeah.
And that too often, when I'm looking at different kinds of therapeutic interventions or programs, right, there's all of this very adultist language around calm child. And calm does not mean regulated. And, so really being able to look at what does it actually mean to have a space where children are able to express, and that children who may appear calm but are actually internalizing all those effects are still getting access to resources that are healing centered, and that we're not just kind of putting labels on kiddos and then trying to get them to act in ways that adults want them to act, right?
So powerful. And I wanted to acknowledge one of the comments from someone just around effects. And I think it's so powerful because it was definitely something that I saw a lot of in my experience as an advocate. But talking about survivors having memory loss and having a hard time focusing and things, we know that there's a huge number of survivors who have traumatic brain injuries as a result of what they've experienced. And so not being able to retain information, or not being able, you may see some difficulty, and you may think it's more of a learning disability or something like that, but understanding that too can be an effect, that it can affect them in that way. So I wanted to acknowledge that. So you all have said so much already, but I just wanted to put out the question: are there any, you have clinicians, other therapeutic folks who work with families and children in communities who are impacted by violence? What would be some best practices? Like, hey, if you want to support a survivor and their children, these are some things that you need to do. I wanted to give you all space to offer that. What are some things that they definitely want to make sure? And it doesn't have to be just whatever comes, there's a wide variety of things, but just what is important in your experience that they
I'll
do?
jump in. First and foremost, to recognize what is domestic violence. So there's a wheel of behaviors that are displayed by people who want to power and control. So make sure you kind of have an understanding of what those are. So when you hear them, you can begin to identify them. But more importantly, just want to also note that survivors are from unborn babies through the elderly. So when you're assessing, you're always listening for what might be going on. but also more humanly is to be able to provide a warm welcome, a warm reception to survivors, to just make a space for them to be comfortable. As you just mentioned, that don't expect a linear story and don't be judgmental. Because sometimes even I'll speak about maybe in the shelter when people come in and people expect to be doing the assessment and everything's going to go smooth. That person just wants to be safe.
Yeah.
Whether it's a male or female with their kids, they just want to be safe. So be cognizant of that it's not always the first time you do an intake that you may get the full story. You need to give people time to think through. And just to remember again, as I said, people want safety, they want justice, and they want healing. But they also have basic needs. Like think about some clinicians are not trained to think about how to find shelter, how to get food. They're trained for providing mental health services from diagnosis. So you also have to remember that. And social workers are trained to know this through our competencies, but a lot of other professions may not know this. So just remember to bring your humanness. If you can't do anything, bring your humanness without judgment. Listen very carefully and deeply to what is needed now in the moment, and and take your time with this person. Bring a lot of compassion, bring a lot of empathy if you can.
Thank you. What else?
I would say one of the biggest things that's needed, regardless of your profession, whether you're a realtor, a school teacher, a plumber, is just the ability to be flexible. A lot of times when you recognize that you're working with a survivor, and I say recognize because it's not always information that's readily shared, depending on what your role or your person. But flexibility is something that is needed because we can't have this checklist of first this, then that, right? To guide how our working or professional relationship with that person would be, because it's never going to operate like that. Because that person doesn't always have full control over everything they need to come to that medical appointment, right? Like I don't have access to all of my health records from the last provider that I saw, or I don't know how to get to my bank account to pay this deposit, but can I meet you and bring you cash so you can fix my plumbing? So flexibility is something that is definitely needed because you never know what someone's dealing with in that moment, in the past, or in their future, because some might have left but are still navigating what that looks throughout that journey. And so flexibility definitely has to be something that you can bring to those relationships, as well as the ability to say, I don't know how to help this person, which is okay. Like we all don't have there's no cookie cutter. I'm pretty sure Gia and I would have two completely different ways that we might want to meet somebody where they are, based upon our training, our experience, and what we do every day. And that doesn't mean that her way or my way is the right way, but the right way is going to be what feels safe for the person that you are trying to help. So ask those questions, be vulnerable with that person and say, you know what, this is my first time in this situation. Do you mind if I consult with somebody? This is what consultation looks like. I won't say your name. I won't say any of this information. I'm going to say, I have an apple that needs this support. Can you help me understand where to get it from? Can I guide them in the right direction? Ask that person, in what way are they open to you helping them, if any at all? Sometimes I think no matter what our profession is, we create this story, right? This vision of what the best solution or outcome could be, or what the best thing that we could do for that person is, but we fail to ask. And so just being mindful that our desire to help in whatever way might not be the way that person needs help. And maybe that person just wants us to listen and not give them a hotline number or an email or a connection in the community. So be flexible. Ask, how can I help you? If you want me to help you, how are you comfortable with me doing that? And hey, I might not know this, but I'm willing to learn with your consent. Like, are you comfortable with me trying to advocate and help for you in this way? And for clinicians, that's going to be really important because consultation is something that happens at any point in our experience as we're providing therapy. We should always be consulting. I recommend consulting with somebody outside of your training. So Dr. Jean made a good point. But the people that I consult with range from MDs to OBGYNs to advocates to social workers to other therapists, maybe marriage family therapy, because all of training and lens and our experiences collaboratively help us create the best environment to help people that are okay and willing for us to help them.
Thank you for that, Marissa.
Yes, and I agree with everything that these brilliant, brilliant women have shared. And I want to add just how incredibly important it is to use an empowerment-based framework
Mhm.
and a validation and strengths-based framework.
Mhm.
Knowing that that whenever we try to get in and try to fix something, that we end up making a mess of things because
Mhm.
people aren't broken.
Mhm.
People aren't broken, right? And we try to fix something that isn't broken, we just make more of a mess. And so instead, thinking about how people are like sunrises, that they
Mhm.
are to be witnessed, to be taken in, to be basked in, and for us to really bask in the glory and the beauty of each person, and to be a big mirror to highlight for them that beauty, that majesty, right? Um, and that far too often, by the time that people get to us, they have experienced a lot of denigration and a lot of control. And so we need to be the total opposite of that. When people feel desperate and are begging for us to make decisions for them, we need to be able to be that healing container and
Mhm.
just stay there with them. It doesn't mean that we withhold knowledge. Knowledge is power. It doesn't mean that we withhold information that's on resources and things that might help, but to really be careful that we aren't just trying to cut corners or take shortcuts and kind of jump in and be another controlling power in their life. Because too often our services, without maybe even realizing it, set up practices that can be coercive. Right.
Yes.
And so, in that way, always looking back through our policies and practices and making sure that we are really eradicating stigma where there's stigma and that we're eradicating that any kind of coerciveness where it's there. And really focusing in on trust building and on being a validating presence.
Mhm.
Far too often, we end up talking, I'll say, just in the mental health sphere around like, how do you get someone to do something that you know they need to do, kind of thing. And that really, our focus needs to be on validating that people are making the best choices they have at their disposal with the circumstances that they have, and that their choices make sense within their context. And that
Mhm.
our role is not somehow to change their choices. Our role is to create an environment where their choices are expanded
Mhm.
and to
Beautiful.
be that validating presence every step along that way.
Mhm. That is beautiful. I had to put in the people are like sunrises. I think that was a beautiful way to put it. And I'll probably add just I cannot stress enough the importance of having and building a relationship with your local domestic violence providers. Like it is critically important because they're going to be the experts in what you may not be an expert in. They're going to be the ones who can tell you about safety planning, who can advocate for these survivors in ways that you won't be able to, in courtrooms with child protection. And so building a relationship, saying, hey, can I come over and just learn more about what you do? Is so important. And also as clinicians, we can't neglect the fact that many of you all may be required to report if someone says that they have, are a victim of domestic violence and there's children in the home. And so being very upfront about that before asking any, probing questions, like really being honest about that. Because sometimes we say mandated reporters, but we don't really talk about what that means. And so it's just not child abuse and neglect, but also children that witness violence. And that can be a huge barrier. And so I encourage you to know what that requirement is and to be open and honest about that upfront, because that can cause a lot of damage if a survivor doesn't know that. And it can open, as we said, just a door to a big system that has the authority to take, to remove children. And so, of course, you do what you need to do and what you feel is best, but you want to be honest about that. So I
May
would
I
just
just add
add
something May I
Uh-huh.
just add something there, Dr. Gia?
Mm-hmm.
When it comes to reporting, I like what you said about explaining to them what is necessary, but
Yeah.
I also just thinking about the humanity of it and trying to understand where a parent may be coming from and helping them. I've often say to clients, I will sit with you and I will help you make that
You call.
report.
Yeah.
So
Mm-hmm.
that it's a voluntary report
Yeah.
versus something that is felt like a punishment in some way, shape, or form. And
Mm-hmm.
I also wanted to add something about the many types of assessments that needs to be done. As clinicians, we hear, we know about CEDV, we know about the ACEs, we know about ages and stages questionnaire for children under 5. We know about again, the CDV is about children exposed to domestic violence scale,
Mm-hmm.
child trauma screening questionnaire. We have clinical administered PTSD scale. There's so many, and some agencies also put together their own assessment to capture everything that might be unique to their community. So you want to get your hands on that or even help to develop it. Depends on what a type of a voice you may have in your agency. And so, yeah, and then thinking about some of the treatments, which was mentioned earlier in the presentation, by Gabrielle, that needs, you can do trauma-focused CBT, you can have groups. There's so many ways that you can help intervene once you recognize that domestic violence is happening in this family. So I just wanted to add that as well.
Thank you so much. I see a lot happening in the chat around. I know that reporting always gets us there. But I will always, because I can't tell you the number of survivors who did not know that a report was being made, and they felt like a sneak attack. And we think that we're helping, right? And again, if a child is being abused in any way, we're not, again, that's not what we're talking about. But just understanding, and last week we talked about systems, how they harm survivors. And a lot of times the survivor is going to be the focus of that report, right? So we have survivors who have been amazing parents, but they have just been victims themselves and their children have been removed. And so just understanding what that means. And so I love this idea that Dr. Jean and those in the chat reference was really, being honest and making that report with the survivor, if you can. So just wanted to put that out there. Go ahead, Gabriella.
Yeah, and something I'll add here is that with the intersection of mental health or substance use or a disabling condition, right? Any intersection with poverty, right? Like any experience that is marginalized and oppressive, you can bet your bottom dollar that that unsafe partner is already making allegations to the CPS system as a way to exert power and control over that survivor and undermine parent-child attachment. And so on top of being sure that we're real clear around our role and our requirements according to our licensure, also proactively working together to help counteract those tactics of abuse because we know they're coming. We know, like, chances are those tactics of abuse are already on their way.
Absolutely. Marissa?
Yeah, I just wanted to kind of highlight and piggyback off of what Gabriella and Dr. Jean have said, but there's a big cultural component to child rearing or elder caregiving. I think that's one population that we haven't really spoken about, but how domestic violence in the home can also impact maybe a mother or grandmother that is also in that home. And so you have to consider cultural norms. And when you think about making a report, because sometimes what might be abused in American society might be a normal way to redirect behavior. Doesn't mean that we have to agree one way or another, but we really have those conversations with our clients in therapy or our people that we are advocating for so that we understand their perspective and help them understand why, because we're here and this is what our license requires, that we might have to make that report together. So there's a big cultural component to mandated reporting or making reports that I think is lost, that we're not trained on as clinicians going through our clinical programs. Because what looks like a spanking in my community might look like child abuse in another. And then some states have that palm, don't leave a mark rule, but to someone else, what they say verbally could be more of an abusive tactic than the impact of top on the bottom. So just being mindful of our awareness, biases, blind spots, and social constructs around child abuse. For some of you that might be licensed in one state and several. And so what I do in one state might dictate or look different for a certain situation than another client. So not only being aware of what that looks like for each of our lenses, but for our clients that come to us with so many different backgrounds, especially for immigrants who are undocumented, that might have language barriers, that need to make a call with your support. So just be mindful of maybe other ways that we might need to support clients when making a mandated report.
Mm-hmm. Thank you for that.
Yes. And the way we document our services can really help protect survivors, right?
Mm-hmm.
So, anytime that we're documenting a mental health symptom, we should be asking ourselves, how is this symptom related to the abuse? And am
Mm-hmm.
I documenting that connection
Mm-hmm.
and the ability for this symptom to resolve with safety and support?
Mm-hmm.
How are we asking about and documenting survivors' protection of children,
Yeah.
right? If a survivor isn't able to access a service with us, are we documenting the sabotage that they're experiencing in their attempt to access that therapy or take that medication, right?
Yeah.
So all that like we play a really big role when and if these dangerous systems get activated. Our documentation will come into play there.
Mm-hmm. Yeah, last session really went into detail. So I encourage you all to please watch that recording because documentation plays a huge role in what happens to survivors and how we say things. So we are getting close to our time, and I just wanted to see if there was any considerations that you all can offer or thoughts as it relates to, and I think, Marissa, you kind of started this conversation, but really thinking about those from marginalized and historically oppressed groups and populations, such as those who are, are BIPOC, Black, Indigenous, or people of color, those from the LGBTQ plus community, immigrant, et cetera, just any other considerations that folks need to think about as it relates to working with those populations related to IPV. That we haven't already addressed. I'm sorry, go ahead.
Yeah, one thing I'll say is that part of being um, part of having a marginalized or targeted identity also means that anywhere where there is stigma around something, that we are much more likely to experience judgment and punishment rather than compassion and care, and that we're much more likely to experience surveillance rather than being given the benefit of the doubt. And
Yeah.
so the way that that translates to our programs is that we tend to get much more stigmatized mental health diagnoses with a lot less access to care. And we also tend to get a lot more surveilled in programming. So we might be doing the exact same thing as somebody else. We might have been a few minutes late. We might have, missed a copay. We might have missed signing a form, right? But our behavior is much more surveilled. And then once it's surveilled, then the response is very often a judgmental or a punitive one. So rather than we miss something or we made a mistake or we're struggling with something, we are the mistake. We are the problem, right?
Yes.
And so recognizing that anywhere in our programming where there is any kind of punitive approach to something based on a policy, recognize how that, rather than a compassionate approach, recognize how that very easily can get rolled out in a way where it really harms people who already experience marginalization and oppression.
Very good. Thank you.
I definitely echo everything Gabriella said. I actually left the movement because of the oppression within the systems of being an advocate, of being a therapist. And that's what pushed me to launch my own business, because I wanted to create that space that wasn't so restrictive. So just be mindful of how you are communicating, because sometimes, 100% of the time, it's not what you say, it's how you say it. But understanding behind pushing a client to get those copays. in navigating, the system in a way that can be supportive of your understanding of what someone could be going through. And it goes back to just communicating, understanding that it's not our responsibility to fix everything or have all the answers, but allow the person you're working with to guide what that looks like based upon what makes them feel safe and what is comfortable for their current situation, because it might change. You might have all the copays and punctual attendance 1 month, and then next month it might look a little bit different. And so what people are experiencing will also change. So just remain flexible in how you're providing care and services to the.
Thank you, Marissa.
Yeah.
Go
So
ahead.
for
I'm sorry,
me,
Dr. G.
that's okay. For me, I just want to bring to awareness the issue around time for people of color and people who have disability and people who are immigrants and all the diversities that we bring, that sometimes it's not on purpose. You know, a lot of times people are oppressed or marginalized, have difficulty with transportation. You know, as Melissa just said, they have difficulty with finances. All of that stuff is going on. So try to really explore and assess, because sometimes these things bring shame. So it's not always something that's easily divulged by clients. Just kind of find out where they are, meet them where they are, and figure out ways that you can get them the support. Make those warm referrals to other agencies. Maybe they're not collecting their benefits yet. Maybe they're not, some of the stuff that life could be better for them, easier for them. It's not happening. So just kind of bear that in mind when you think of people from marginalized communities. And I think of people of color, they're Black people, and then there are other people of color that sometimes are treated differently. As you know, Gabriela just said, who is policed more? By the darker skin tones or your accent. All those things are used against us. So we need to be very cognizant of that and have compassion around that.
I think too, I'll just add that, I mean, when you talk about those from marginalized, groups, just understanding that and why they may be reluctant to engage systems, why they don't want to call the police, why they don't want to make reports, because of the distrust and the mistrust of systems because of how they've been harmed. And so just understanding that and being sensitive to that as you're having your conversations, and even recommending things as well, and respecting that, right? That, I know the police, you calling the police may be easy for you as a white woman, right? But for me, it may not be as easy because of my experience. And so, or to, a heterosexual couple, that may be taken very differently than if I say, I'm a woman and I'm being abused by my female partner. And so it's just things like that definitely need to be considered. So I want to make time for questions. So I put in the chat, if you have any questions, please put a Q so that I know it's a question, and we will try to get as many as we can in the time that we have here. So I want to just before I move into questions, just thank our panelists for your rich feedback and just all that you offered our session today. So I have a question from Leanne, and they say, I'm wondering about how to help someone who may be showing signs of being the abuser in their own response to trauma, recognize their actions and how they affect their family members and children. Any thoughts about that, about someone who may be causing harm, how they might help them?
When I was working in substance use and mental health care, I worked with a lot of people who caused harm, but they weren't people who were mandated. We didn't offer battering intervention programming. There were people who would come for help with substance use and mental health, and then in the course of that, recognizing that they were causing harm or had caused harm. And something that actually I found really effective in working with people was a combination of motivational interviewing and acceptance and commitment therapy.
Thank you.
Both of these together I found really helpful for folks in both accepting the reality and committing to changing that reality.
That's really good. Anything else?
I think sometimes people are unaware of their behavior as being abusive when it's not physical or so yelling and screaming, that they're doing things. So I think helping that person to understand that the intent might not be the impact. So what you're doing to someone is causing them harm. And so you need to be able to understand that and change behavior. I think some awareness helps.
Yeah. Any other thoughts about that?
I would just say be cautious in how you start to have that conversation, especially if you are presenting it to your client and not your client mentioning it to you, because it could definitely do a little bit of damage to the therapeutic relationship and bringing that up into what is that person's safe space in therapy. So you want to explore or maybe probe the client in a way that they can come to some of this self-determination and self-decision making around their behaviors and the impact on others, because again, you are that safe space for the person that might be perpetuating some aggressive behaviors themselves. So use examples, but not necessarily blame. You don't want to just put blame on the person that is reacting. And a lot of times the reactive abuse is coming from a defensive place. So explore how you feel defensive before we get to a point of, hey, you're actually perpetrating abuse here. So just be cautious in how you communicate that, how you present other modalities. Maybe if you weren't using ACT before and you want to recommend it. So explore to your need internally. So some self-reflection around why this is something that you need to bring up in this moment, especially if those behaviors aren't behaviors initially or at any given moment that have required a mandated report. So be mindful of your first priority to make sure that that client feels safe while you continue to work with them.
Thank you for that. And I love the fact that we have to understand that just because someone has been charged with domestic violence doesn't mean that they are the perpetrator. There's a lot of survivors who are blamed, or there's a mutual kind of blaming in states, right? There's a practice where both are going down. Especially if there's children. So really understanding it. And so these other sessions were to help you all to understand the power and control dynamics, to understand.
That's your microphone.
To understand the power and control and how that plays out, right? That physical violence does not have to be present for there to be power and control, or for someone to be murdered. We saw that with our initial survivor who shared her story of being and never being physically hurt, physically abused. So just all of that was really a buildup. So I want to offer that. And when it comes to men who perpetrate violence, or in my experience, oftentimes we cannot change behavior by getting them to see the way that their violence has harmed maybe their female partner, if it's a male-female dynamic, because they may not care about that, but helping them to see how it has impacted their children can sometimes really be a eye-opener. Like, let's talk about the children versus, because again, they may have a closed eye to the partner and may do the blaming thing, but research shows that that many of them want to be good fathers. Many of them want to and love and protect their children. And so sometimes showing them how their violence towards their partner impacts children can also be a helpful way of bringing some information and getting them to at least open up and try to get some help. All right. So I'll take maybe one or two more questions. A lot of cues. Someone wanted to know just how can we counteract this idea of battered women syndrome? We know that is like old school language, just this idea that battered women have this mental health condition or complex, right? And we have the way that we have put these survivors in a box, and that there's something on the inside wrong with them, right? There's low self-esteem. There's all this kind of stuff that we've kind of put into this syndrome. So I'm just somebody wanted to know, was there any thoughts about that and how we might counter that?
I'll jump in on that quickly and use myself as an example. I was never stupid. I was never any of those things that we get labeled. And when I first went to the shelter, they didn't want me to take the hotline training because they're like, you're a battered woman. So I think, but that was 30 years ago. Now we're seeing how much strength, how much post-traumatic growth, how much, so many ways where, each one of us are
Yeah.
The panelists are survivors. And look at us, how strong we are. So we have to go from strength. From the beginning, from the very first contact, we're looking at strengths. We're bringing out strengths. So we need to publish more and talk more about what we have and our children have achieved who were once battered.
Yeah. I was going to say the same thing. Look at our panel. Like that is defying battered women, defying that. Go ahead, Gabriella.
Absolutely, 100%, Dr. Jean. I couldn't agree more. And I think something I'd add to that, because I often get this question when someone has a colleague that is bringing this up, and they're like, what do I tell this colleague, right? And so I think that having a really deep understanding of victim blaming and how that shows up in our society and continues to show up in our society and in our policies and practices and organizations is really critical. Because if there's a colleague who's still talking about something like battered women syndrome, then I'm pretty sure there's a whole lot of other victim blaming going on in that person and potentially in that system, right? So once we can really understand all the different ways that victim blaming shows up, then we can start to really eradicate that from our systems, because it's everywhere. It's everywhere. It's in our laws. It's everywhere, right? And so we have to counteract that.
I agree. Such good stuff. And I wanted to acknowledge the chat. Someone asked about a good book recommendation, and if you all have someone who is not a clinician and wanted a good book, I'm going to, if you want to understand power and control from a perpetrator perspective or harm doer, I really encourage. I like all the books from Lundy Bancroft. And I'll put a chat in, particularly one that says, why does he do that? And it just really gives a really good look into power and control and how that kind of happens. So do you all have any other book suggestions for folks who want to know more? If not, it's fine, but just wanted to offer that.
I have one book that, and Gia, I don't remember the author, so
Yeah.
I can drop it to you, can go out with the email. And actually, I'm a certified sex offender, and majority of the people that perpetuate sexual violence also perpetuate domestic violence. And so the book gives you a lens into more violence and sexual violence and the intersectionalities of the power and control wheel in those dynamics. And as it connects back to battered women syndrome, there's a whole conversation that happened around how you kind of sweep some of these microaggressions and abusive behaviors that happened within, the battered women syndrome movement, or when batterers intervention kind of became this buzzword around helping perpetrators get help and resources and what that looks like. And so you have to be mindful that just like Dr. Jean and Gabriella, they mend all of these things that happen and how it goes to it being our responsibility. So while we might not be at a place to say, hey, battered women syndrome is not a real thing, we also have to own our responsibilities to be voices in spaces where survivors don't have a voice.
Yeah.
And so, yes, we can share books, but we want to not only create safe spaces to talk about these things with our colleagues, but we want to create brave spaces where we're challenging them to grow, understand their blind spots, so that the agency, organizations, and so forth can move forward with implementing changes to those policies.
So good, so good. And we are just about at the end of our time. And I want to and someone asked, I want to acknowledge it. When will we talk about men? And I think in all of our sessions, everything that we have said applies to male victims as well, male survivors. We use typically she, her pronouns because of what Gabriella shared, that most, when we talk about, statistics and numbers, women are most often victimized. And so we honor that, but it does not mean that men are not also victims. And we know that there's a lot that plays into reporting and numbers. So if you felt that way, we apologize. But all of this information is for any survivor, right? Not just female survivors. So I want to thank our wonderful and dynamic panelists, each of you all amazing survivors, and the epitome of resilience and all of that. And so I just want to thank you all, Dr. Jean, Gabriella, and Marissa, for your time today, for your wonderful contributions. And I also want to thank everyone for joining today and asking questions. And I ask that you will not, this is our last session, and I'm just going to ask that you all would not just let this stay here, but take it back, share your learnings, keep digging into this, read books, read other materials, you know, so that you can build your capacity to work with survivors in a way that is empowering and that helps them get a step closer to healing. All right.
And just say quickly, I shared some resources which will be shared, I think, when the video goes out. So there's some stuff there for NASW and other resources that you can use to continue to learn and grow.
Thank you so much. And there is a resource list that's in the slide deck as well that will be shared. So please take advantage of those resources from Gabriella as well as some others. So thank you all for your time. Have a good rest of your day. And that concludes our webinar series. Bye, everyone. Thank you.